Hello, everyone. Thank you for logging in. We're going to wait just another moment or two as more people seem to be logging in to view, and then we'll get started. We'll wait just maybe another moment here. All right, and we'll go ahead and get started now. Thank you so much for joining me this evening and being here to listen to my talk. So my name is Jennifer Hellman. I am a pediatric nurse practitioner at CS Mott Children's Hospital, and I work with the pediatric otolaryngology group there. So I've been a nurse practitioner for 16 years. The last 6 of those years, I have worked with pediatric otolaryngology. I am primarily inpatient based in my role, and I do often work with airway patients. As far as NAPNAP involvement, I am the treasurer for our Michigan chapter. I'm also involved in Partners for Vulnerable Youth Foster Care Alliance, and I'm currently a member of the Health Policy and Advocacy Work Group with this. I am excited about our upcoming conference with NAPNAP in Orlando in March. I will be doing an acute care concepts talk on Thursday morning, so I hope to see a lot of you there. Today we're going to be talking about common reasons why a child might see an ear, nose, and throat specialist. So we're going to be discussing signs and symptoms that you might be seeing with different ENT conditions, as well as possible treatment options. And my hope with this is that you know more of what to prepare families for to expect when a child is referred to an ENT specialist. This is going to be covering a lot of information pretty briefly, so I am going to be including some resources at the end that you could use to review these topics a little bit more in depth. First, we're going to be talking about acute otitis media, or AOM. And with this, we have a rapid onset of signs and symptoms associated with inflammation of the middle ear. And with this, you're going to see a bulging TM and presence of a middle ear effusion. With this, you can have persistent AOM, meaning there's a persistence of symptoms despite antimicrobial therapy, and or a relapse of AOM within a month after completing an antibiotic treatment. You could also have recurrent AOM, and this is 3 or more documented in separate AOM episodes in the last 6 months, or at least 4 documented in separate episodes in the last 12 months, with one of those being in the last 6 months. Tympanostomy tubes are a common treatment when children do have persistent or recurrent AOM, and it is really the most common ambulatory procedure performed in children. As far as treatment with AOM with the middle ear effusion, bilateral tympanostomy tube placement would be offered. The child's hearing would need to be checked if that hasn't already been done. Children greater than 4 years old, there is an option of doing an adenoidectomy along with ear tube placement. These children would be rechecked in clinic 3 months after surgery with a hearing test. They're going to be assessing to make sure the tubes are still in place or what the tympanic membrane is looking like. If ear tubes are not placed, these children that do have these symptoms with persistent and recurrent AOM will need surveillance every 3 to 6 months. We're going to move on next to otitis media with effusion, or OME. And with this, we have presence of fluid in the middle ear without presence of infection. And this could occur during an upper respiratory infection. It could occur spontaneously due to poor eustachian tube function, or as an inflammatory response to AOM. The symptoms that you would see with this might be vestibular balance problems, poor school performance, behavior problems, complaining of ear discomfort, and having recurrent otitis media. The children that are high risk with OME are children that already have permanent hearing loss. They might have a speech or language delay, developmental disorder, syndromes or craniofacial disorders that have cognitive speech or language delays associated with them, blindness or vision impairment in children with a cleft palate. It's really important to document the presence of effusion if you're noticing this on exam with pneumatic otoscopy and noting the date when the diagnosis occurred. And this is so we can check to see if the effusion is chronic, meaning lasting longer than 3 months. There is reports that maybe effusions are not appropriately assessed because people do not use pneumatic otoscopy with insufflation. And this is really the better way and more definitive way to check for OME. And this should be checked in a child that is complaining of otalgia or has hearing loss. You can also obtain tympanometry measurement if you suspect OME and the diagnosis is uncertain after you do pneumatic otoscopy. The treatment for OME really depends on risk factors, the child's symptoms, and the clinical findings. You can manage with watchful waiting for a child that's not at risk for 3 months from the date of effusion. If the OME is not resolving, that child does need to have their hearing monitored. If you notice eardrum damage or symptoms, surgery is going to be offered. If the child has bilateral OME with hearing loss, surgery will also be offered as well. If the child is not really having symptoms, but this effusion is still persisting, it's going to need to be monitored every 3 to 6 months until it resolves or until the child starts to develop symptoms that might lead them to needing surgery. As far as surgical options with this, a child under 4 years old would be having tympanostomy tubes placed. If they're over 4 years of age, they would do tympanostomy tubes and also possibly an adenoidectomy. Along with ears, we're going to be talking about pediatric hearing loss. And with hearing loss, we really have two main types. So the first type is sensorineural hearing loss, and this is caused by loss of function in the inner ear or with a connection to the brain. And this is a permanent form of hearing loss. And this can be due to genetics, due to an infection, maybe CMV or meningitis, having head trauma, noise trauma, an anatomic abnormality, or even certain medications. It can also be idiopathic. The second type of hearing loss is conductive hearing loss, and this is when the sound waves are not sent to the inner ear correctly due to a problem in the outer ear or the middle ear. This is the most common type of pediatric hearing loss and is usually acquired, although it can be congenital, and usually is temporary and caused by fluid in the middle ear, like we were just talking about. TM perforation can also cause this, having excessive earwax, a foreign body in the ear, or more rarely a tumor. The signs and symptoms that you might see in a child with hearing loss is that they don't startle to loud noises. They might turn the volume up excessively high when watching TV or listening to a radio. They don't respond when their name is called. They might have difficulty articulating words, have a speech or language delay, difficulties in school, complain of ear pain or head noises. They might have difficulty understanding what others are saying or give an inappropriate response to a question. There are different hearing tests that we use to check for hearing loss. So the newborn hearing tests that are used are the OAE, or the otoacoustic emissions, and the ABR, which is the auditory brainstem response test. When infants get a little bit older, and with children, there are behavioral tests that can be completed, and there are different types of tests that are done based on their age and their ability to interact. You can also use tympanometry for hearing tests, acoustic reflexes, and when we're struggling and having issues getting a good hearing test for whatever reason, sedated ABR can be completed. So this would be done under anesthesia. At my hospital, we typically tried to coordinate this if the child might need anesthesia for another test or procedure. So that way they're not having multiple episodes of anesthesia. The treatment for hearing loss can really vary based on the severity of what the hearing loss is. So the child might benefit from hearing aids to make the sounds louder. There are FM systems that can be used for noisy situations, like in a classroom, to amplify the noise for the child. Surgery can be done to correct if there's a structural deformity. Some children would be candidates for a cochlear implant if they're not a candidate for another surgery or hearing aids. And there are also bone conduction aids that can be used. We're going to switch gears a little bit now and talk about sleep disordered breathing. This can include central apnea, abnormalities of ventilation, and also obstructive sleep disorder breathing, which involves obstruction causing abnormalities in the respiratory pattern during sleep. So this can include symptoms of snoring, mouth breathing, and even having pauses in breathing. And there really is a full spectrum with this that increases in severity from just regular snoring all the way up to obstructive sleep apnea. It is reported about 10% of children have primary snoring when we're kind of looking at the lower end of severity. But when we look on the higher end with OSA, this occurs when sleep disorder breathing is accompanied by abnormal sleep study. And when they do sleep studies, there's different values and testings that they're looking at. And one of those is the apnea-hypopnea index. And if that index is greater than 1, then that child would be diagnosed with OSA. Daytime symptoms that you might see in a child with sleep disorder breathing could include difficulty paying attention, poor concentration, hyperactivity, or excessive sleepiness. They might also have problems with enuresis, aggression, anxiety, and depression. You can also see failure to thrive symptoms in pediatric OSA patients. The treatment really varies based on their symptoms and the concerns. The child might get referred to a sleep specialist or to a sleep clinic. They might need to wear a nasal mask for non-invasive positive pressure ventilation. They also require evaluation, potentially for possible surgery. So this can include something that we call a DICE or drug-induced sleep endoscopy. And with this, the child is under anesthesia, and endoscopically, they look at the upper airway to see areas of the airway that might be causing obstruction or collapse. And then based on that information, there might be different surgical options that could be available to that child. One of those might be a tonsillectomy and adenoidectomy, which we will be talking about next. So tonsillectomy is one of the most common procedures that's performed in the U.S. on children, and one of the big things that are seen in ENT clinics every day. And when we think about tonsillectomies, there's really two most common indications for them, which are recurrent throat infections and obstructive sleep disorder breathing, with tonsillar hypertrophy really causing like crowding of the oropharynx. So when we're looking at these different criteria with recurrent throat infections, this would be if the child is having more than 7 infections per year, or having 5 infections per year for 2 years, or 3 infections per year for 3 years. And if this is not documented well, you could also consider tonsillectomy if they're having periodic fevers, aphthalostomitis, pharyngitis, and adenitis. If they don't meet the criteria, then watchful waiting is usually what is done. With the second indication of obstructive sleep disorder breathing, if the child's less than 2 years of age, if they have Down syndrome, obesity, a craniofacial abnormality, neuromuscular disorder, sickle cell disease, or mucopolysaccharidosis, then they would be referred for a sleep study. If the sleep study does show obstructive sleep apnea, then a tonsillectomy would be recommended. If the child is having growth issues, along with their sleep disorder breathing, poor school performance, enuresis, behavior problems, they would also consider the option of a tonsillectomy. If the need for surgery is really uncertain, or if there's any discord between what is assessed as far as the tonsillar size and the reported severity of the sleep disorder breathing, then that child would be referred for a sleep study just to obtain that information to know if they truly do have OSA. As far as with tonsillectomies and adenoidectomies, the bleeding is the most common complication. This is typically seen in the first 24 hours. And then also can be seen again, usually at 5 to 10 days after surgery. And the bleeding can really vary in severity with this and can actually be quite serious. So a child may need to go back to the OR from cautery or those types of things because we don't want to get into a life-threatening situation with bleeding. Typically, these children do improve following the procedure with decreased infections for 2 years afterwards and reports of better behavior symptoms. We're going to move on next to sinus issues. Pediatric sinusitis. With this, typically children are going to have a cough, bad breath, crankiness, a low energy. You might see swelling around the eyes, thick kind of yellow greenish nasal or postnasal secretions. This is usually viral, but it could also be bacterial. And it can also be sometimes difficult to diagnose since the symptoms could be similar to a viral illness or allergies. With acute sinusitis, most kids respond well to antibiotics if it's bacterial. Also, nasal steroid sprays and saline drops or sprays can be really helpful to help with stuffiness. With chronic sinusitis, the child has 2 or more symptoms of sinusitis for at least 12 weeks or longer and has signs of sinus pressure. And this is usually caused by prolonged inflammation as opposed to infection. So they really should be seen by ENT if they've had more than 4 to 6 episodes of acute sinusitis per year. And when they are evaluated, surgery may be recommended if they're still having symptoms despite medical treatment. And that would mean allergy medications, topical nasal steroid sprays, or saline irrigations. And as far as surgical options with this, one option would be an adenoidectomy or considering FES, which is a functional endoscopic sinus surgery. And in this procedure, the sinus passages are enlarged and any growths are removed to open the sinus passages up. We're going to move on next to ankylosing or tongue tie. And this has really been a long concern for practitioners. So in preparing for this talk, I read in a surgical textbook in 1679, they had a picture of a surgeon performing a frenotomy on an infant. And there's also reports of midwives in the 18th century keeping one of their fingernails long. So when an infant was born, they could lyse the frenulum for that child, to more effectively potentially breastfeed. There has been a large increase in the number of infants diagnosed and treated for ankylosing in more affluent countries and in certain communities. And this is really mostly because there's been an increased focus on the benefits of breastfeeding, which is good, and also awareness that tongue tie could impact breastfeeding. And there's also more lactation consultants around to identify infants that might have ankylosing as well. Despite this kind of increased number of infants diagnosed with this, really the benefits and indications for intervention are still really unclear because there's just not really a lot of evidence with randomized controlled trials to know if this is beneficial or not to treat it. Infants with tongue tie can also have issues with breastfeeding, though not all infants have feeding problems that do have tongue tie issues. Nipple pain and poor latch can also be caused by ankylosing, but it can also be present for other issues as well. So when these babies are referred to ENT, we really need to get a good full history and an assessment. And we'll be evaluating for other head and neck sources for breastfeeding problems, like a nasal obstruction, maybe choanal an airway obstruction, reflux, a craniofacial anomaly, such as a cleft palate. And it's really helpful to know if the mother and infant has already worked with a lactation consultant to know that this isn't related to positioning, as that's a common reason why infants have a hard time latching. Some contraindications to treating ankylosing would be retrognathia, micrognathia, a neuromuscular disorder, hypotonia, or coagulopathy, because intervening with a frenotomy can make things worse. If the infant's having problems and the other factors are ruled out, then a lingual frenotomy should be performed as soon as possible to prevent that mother from stopping breastfeeding and to also hopefully help that child feed better and latch better. This is typically done in clinic for infants and usually just done with oral sucrose. There's not usually a topical anesthetic that is used. Now, when older children have ankylosing, they're usually going to have more mechanical and social issues. So they might have difficulty licking, difficulty keeping their teeth clean, having social embarrassment, and they would likely need to go to an OR for the frenotomy, as they would likely not tolerate that well in the clinic environment. Now we're going to be talking a little bit about airway issues for our last few minutes here. And this is something I deal with more with in my current practice. So when a child is presenting with noisy breathing, stridor, increased work of breathing, we really need to figure out why this is happening. So reflux is one thing that can play into this. So if a child or infant's having reflux, this can cause inflammation of the airway, and it can really complicate the picture sometimes as to what's going on. So it's not uncommon to go ahead and start a child on anti-reflux medications in our clinic to see if there's improvement in their symptoms. And when we're looking at airway issues, one of the things I I said, that we might be seeing with stridor. And really, your physical exam can be very important to help you determine the cause or maybe where the issue is occurring. So with stridor, if we have inspiratory stridor, it's an extrathoracic obstruction that is happening. With expiratory stridor, it's an intrathoracic obstruction, and with biphasic stridor, it's both. Laryngomalacia is the most common reason for stridor in infants. With this, we have kind of mild, moderate, and severe. With mild laryngomalacia, there's inspiratory stridor with really no other symptoms or airway concerns. So with these infants, you can really usually just kind of watch them and do a 1-month symptom check. If they're stable or things are improving, you can space those visits out for every 3 to 6 months. With moderate laryngomalacia, the child might be demonstrating coughing or choking, regurgitation, and really a lot of feeding difficulties. These infants would be started on acid suppression therapy and would also consider a feeding therapy and swallow evaluation. With severe laryngomalacia, really the symptoms are very scary and definitely very worrisome. So these infants can have apnea, cyanosis, failure to thrive, even pulmonary hypertension. So similarly as kind of the moderate category, they would be started on acid suppression therapy, and we would usually refer for feeding therapy and swallow evaluation. But we really need to be very proactive in, monitoring these children very closely and acting quickly if they're falling off the growth curve, if they're not gaining weight, if they're aspirating, if they're continuing to have respiratory issues, then we really need to consider surgical intervention with a supraglottoplasty. So with the supraglottoplasty procedure, it's done in the operating room. Typically, the babies would then spend 1 night in the hospital. In our hospital, they spend the night in the pediatric intensive care unit. If this laryngomalacia is not so severe and the child is able to safely gain weight, it can improve on its own as the child gets older, and you really can just continue to watch and monitor the child. Vocal cord paralysis is the next topic, and it's the second most common congenital laryngeal disorder. It can be unilateral or bilateral, and sometimes the cause of this is unknown. Other reasons could include a Chiari malformation, having birth trauma, a heart surgery where there might have been nerve injury, or any other reason there was injury to the recurrent laryngeal nerve. A child with vocal cord paralysis is usually going to have a breathy or a weak voice, have a weak cry. They might have stridor. It might have issues with aspiration. Flexible laryngoscopy is done in clinic while the child is awake to evaluate the vocal cord mobility and to look at the function. Based on this, the child might need a follow-up direct laryngoscopy and bronchoscopy in the operating room to further evaluate the airway. In some rare cases, an EMG might be performed to assess the nerve function in the vocal cords. A child might also need an MRI if the cause for this is unknown. Vocal cord paralysis can improve on its own. The child may need thickened feeds or tube feeds if they're having issues with aspiration. There are reinnervation procedures and filler injections that can be done if it's not improving as the child gets older. Tracheostomy might also be required if the airway isn't stable. And for bilateral vocal cord paralysis, as the child gets older, like a larger airway endoscopic procedure could be completed. Lastly, we're going to be talking about tracheostomy, and there can be really many different reasons why a child might have a tracheostomy. And when I think about these, I kind of think about these in different categories. And the first category would be a primary airway issue, and there could be many things that would fall underneath this. Some examples might be subglottic stenosis, a tumor or a mass, malacia, or a craniofacial issue. If there's a respiratory issue or an issue with the lungs, this might be bronchopulmonary dysplasia, especially seen in our preemies, or the child might have had ARDS and need some time for their lungs to recover and might require long-term mechanical ventilation. There are also neurological reasons, including, for example, a spinal cord injury, a progressive neuromuscular disease, or issues protecting the airway due to secretion burden. It's helpful as a practitioner to always know why a child requires a tracheostomy, and For many of these conditions, often with time things get better, or with intervention they can get better, but for some of these children, the tracheostomy will be permanent. But it is always our goal to see what we can do to get the tracheostomy tube out if that is a realistic goal for that patient. These children are going to have routine follow-up with their ENT provider. Typically, these visits will be every 3 to 6 months. If the child is more of a chronic patient and not much is changing and the trach tube is maybe not coming out, those visits might be yearly. Sometimes our surgeons will do routine airway evaluations to assess the airway and see if there's any problems that need to be addressed, especially to work towards our goal of getting the trach tube out. Some surgeons do not routinely do this as well. So we have covered a lot of information this evening, and I really appreciate you participating in this. So I am happy to take any questions that you might have. I can stay on for a few more minutes. I can also answer them tomorrow in the chat as well. You're also welcome to contact me on the NAPNAP membership directory if you'd like to speak about things or have any questions to ask me directly. I'm also going to be putting some resources in the chat. As I say, this was a very brief overview of things, but I'll include some resources that are helpful for providers as well as families. Thank you so much. All right. I have to get a little oriented to my screen, so just give me a moment. So Kristen, I see your question. So she was asking about if the family is noting pauses in the breathing and they have tonsillar hypertrophy, is a sleep study required before a TA? So I think some of this can be dependent upon conversation with the family and figuring out what makes the most sense. I think some practitioners might want to go ahead and get a sleep study. Others, if there's enough demonstration of symptoms and those types of things, they might be comfortable going ahead and proceeding with the tonsillectomy. Well, thank you so much for everyone participating this evening. I really appreciate it, and I'm really looking forward to seeing everyone hopefully in March at the NAPNAP conference and celebrating 50 years and their 50 forward with the gala event and all the exciting celebrations. So I hope to see everyone there, and thank you so much and have a great night.